Respected chairpersons, all the delegates, and my friends, seniors and juniors, a very good morning to all of you. And it's indeed a pleasure and honor to be on this August platform of Diabetes India and speaking on insulin stewardship. So, dear friends, the concept of stewardship originated in the WHO World Health Report 2000, which was more centered around how the government should own the health system of different countries. So, function of a government responsible for the welfare of the population, concerned about the trust and legitimacy with which its activities were viewed by the citizenry. Now, this concept has been taken forward and it has been applied to many real life settings. You must have heard about antimicrobial stewardship. You must have heard about steroid stewardship. And so we are also going to talk about insulin stewardship and why it is important in our day-to-day practice, in our clinics, in our hospital settings. So why insulin stewardship matters? Insulin stewardship is the rational and evidence-based use of insulin to optimize patient outcomes with minimizing harm. What is the core problem of the misuse of life-saving therapy? So insulin is undoubtedly a life-saving therapy for many, yet it's frequently either low used or high used. So it's basically the clinical inertia, inadequate patient education, suboptimal access strategies. And sometimes the misuse leads to significant issues such as overprescription without considering alternatives like GLP-1 receptor agonist or SGLT2 inhibitors. So basically here what we are trying to say is that the clinician has to take the ownership of prescribing the insulin at the right moment of time in right quantities to the right kind of patient so that the clinical outcomes improve. So there are certain clinical challenges. Overprescription, inappropriate intensification, and poor titration practices contribute to insulin misuse. There are patient level challenges like poor adherence, affordability issues, incorrect administration techniques which hinder effective insulin use. And there are systemic challenges as well. There is variable insulin pricing and the lack of structured initiation protocols that exacerbate the problem. If you go to different hospitals, you will find there are hospitals who are still using the sliding scale, although it has been considered outdated. If you go to the clinics, you will still find physicians who are either hesitant or who are using it just like any over-the-counter drug. So we have got both the kind of extremes. So there are 5 rights of insulin stewardship which I believe in. The first is the right patient. So unless and until you are able to choose the right patient for the treatment, it's of no use. Second, the right dose. The third is the right timing. And then obviously de-escalation strategies. Whenever we are giving, say, with a particular agenda in mind, sometimes patients comes only for a surgical procedure and they want a rapid control of their glycemic levels. Then we need to also plan de-escalation strategies. And the last is the preventing clinical inertia. So again, a case example, the overprescribed insulin user. Consider a 60-year-old patient with type 2 diabetes mellitus who is on basal bolus despite obesity and residual beta cell function. So either there should be a de-escalation strategy with to GLP-1 RA or initiation of basal dose reduction. That will eventually lead to better weight control, and we can also look at other molecules like SGLT2 and metformins. Then there is an underutilized insulin user, say suppose a 50-year-old with long-standing type 2 diabetes mellitus, HbA1c more than 11%, symptomatic hyperglycemia, but still on oral therapy, and the clinician is most probably here not confident enough to start insulin due to one reason or the another. So here early basal insulin initiation along with metformin plus SGLT2A will lead to improved faster glucose control and prevention of glucotoxicity. Now coming to what are the different components of insulin stewardship. The first is the insulin inventory management. So ensuring availability of insulin in your hospital settings or in your center settings is very important. So the preparation or the trade name that you are going to use, that will also depend on the cost and the availability in the local market with continuous supply chain, the strength or the correct dosage of glycemic control and delivery device like for if you are catering more to a kind of an intellectual, more paying capacity, the pen devices are more suitable. If you are looking to a more marginalized community kind of settings, I think vials and syringes are more of the use. So it depends on the kind of setting you are practicing. Now, insulin initiation with a proper prescription, selecting insulin as per the right condition. The counseling of the patient is very important. Counseling of the primary caregiver along with the patient, their relatives, the people who are accompanying them, making them understand the importance of giving insulin and the right injection technique. That is also very important. Explaining about the sites where insulin injection can be given, the importance of rotation of the site, the importance of discarding the needle after use. These are all important things. The insulin monitoring or the continuous optimization, so regular testing to assess efficacy of the regimen, recognize and manage low hypoglycemia or hypoglycemia incidence, adjust dose based on readings and lifestyle to aim for control. Insulin safety, minimizing risk. So again, injection technique, disposable of sharps, it's very important. Unless and until you are having a institution level policy or a clinic level policy, your staff is not going to follow that. Please bear that in mind. So that is very important. Avoiding needle stick injuries, both for yourself, your staff and the patients, that is also again very important. Another important point which is often neglected is fostering peer support and community support. So whenever people are initiated on insulin, it is important that they kind of have a peer support group where they are kind of guided by their own likes. That is very important. So patient education sessions should empower the patients. Support groups, if we are able to form that within our settings, nothing like that, that will eventually encourage adherence through community engagement. The importance of proper injection technique, again, a very important point. Consistent absorption, reduce complications and improve outcomes is what it leads to. Now the power of technology. So we now have CGM devices. We are also looking at a situation where most probably we'll have smartwatches measuring non-invasive HbA1c or sugar levels. So the future is quite bright, and we should be open to all these ideas whenever they come with proper validation and robust evidences. So as I said, institutional level insulin stewardship guidelines should be there. Clinical pathways should be hospital protocols should be pasted at all the wards and ICU settings. Diabetes educators should be there for kind of empowering nurses and pharmacists to educate patients on proper insulin use. And guidelines integration like ADA, ASD, RSSDI, and Diabetes India, whatever guidelines are available, they should be incorporated in the practice. Now again, at the national and international level, we have global initiatives like WHO's essential medical list. Affordability solutions are required to kind of encourage generic insulin production in the country, and already it is happening, but newer molecules also need to be produced in the country. Public health initiatives like training program for primary health and community level education is also very important. The future directions of the insulin stewardship is more AI driven or AI components, combination therapies, and insulin monitoring, including CGMs and hypoglycemic awareness. So novel insulin formations which are on the horizon are once weekly insulin, the inhalational insulins, the ultra rapid insulins that are kind of about to enter the market. So these are what excites us. AI driven insulin optimization solutions like your pumps and smart delivery systems. So they are also kind of going mainstream more or less soon. We should also look at combination therapies in conjunction with insulin, like insulin sparing, triple therapy, and dual therapy, including GLP-1 RAs and SGLT2 inhibitors. I will not elaborate on that because a lot of speakers have already said. The glucose monitoring strategies, including SMBG, CGM, and target ranges. So again, very important. The effective insulin titration, this concept is very important because we have to always start low. We have to identify the patterns based on the meal pattern. We have to identify how much dosage is to be given. And the healthcare guidance has a continuous job. It's not a one-way street. And just to conclude, the key takeaways of the presentation are that insulin stewardship is important for optimizing use with minimizing risk. Prioritize individualized insulin regimens based on CGM data, which if we are able to practice in our settings, nothing like that. Incorporate newer therapies like GLP-1 RAs and SGLT2 inhibitors to minimize insulin burden wherever possible. Train clinicians and patients on safe insulin use, storage, and dose titration, and leverage AI and digital tools for better insulin management. So thank you, friends. Thanks.